start. First question is from September 2021, right? Listen carefully. We will discuss the answer and we will discuss why the other options are not selected, right? This is the first question. He's a 5-year-old boy who has recurrent skin infections, pneumonia, and meningitis, right? Always think whenever you do have this skin problem along with other systemic manifestation of the infection, maybe respiratory, maybe GI, maybe CNS, like presence of the skin infection along with this, you must think of this immune deficiency, right? Okay. A 5-year-old boy, he has recurrent skin infections, pneumonia, and meningitis. Uncle died during childhood from meningitis, right? The patient is having meningitis. The patient's uncle was dead, and he was also having meningitis at that time. What is the investigation? Okay, first of all, we have to look which system is involved. Whenever there is skin involvement at any systemic like respiratory, GI, or CNS involvement, you must think of immune deficiency. Whenever you are approaching immune deficiency, you have to categorize which type of immune deficiency it is. Okay. For the September batch, especially, I will not go to straightforward what is T cell deficiency, what is B cell deficiency. Okay. For your exam point of view and for solving your recalls, we will approach immune deficiency in 3 ways. Like we will decide, is this X-linked, is this an autosomal dominant or autosomal recessive? Okay. What we get from this question, which type of inheritance is given in this first question? The baby is a boy, right? Okay. His uncle was also a male. He died due to infection. So this scenario is suggesting me that this is an X-linked disease, right? That is manifested only in the males, right? The patient is having immune deficiency that is X-linked. Okay. What immune deficiencies are X-linked? Can anyone answer me? We have discussed this like in the classes too. You tell me. Okay. What are X-linked immune deficiencies? Anyone, please? Okay. What are X-linked immune deficiencies? X-linked agammaglobulinemia. Please, if you have copy and pencil with you, write on it what are X-linked. Number one, that is X-linked agammaglobulinemia. Number two, yes, glutons are X-linked agammaglobulinemia. They are the same, right? Number two, who's going to tell me which one is number two? Okay, please do tell me. Write down. That is very important. These 5 questions like approaches, they will all solve your recalls. One is X-linked, number 2 is SCID, right? Number 3 is Bisport-Eldrich syndrome, and number 4, that is chronic granulomatous disease. 1, 2, 3, 4. Write them down. These are very important. These 4 are very, very important for your records, for your examination questions, right? So we will see that what is the difference in the presentation of all these. Okay. So what is the difference in the presentation of all these? How X-linked is present? How, okay. What is presentation for the X-linked? That is an X, okay, and it will present usually after 6 months. SCID, that is also X-linked recessive, will present in the male but it will present less than 3 months or 6 months. So the baby who is less than 6 months, he presents with recurrent signs and symptoms of the infection. Plus, the clue is that this disease is X-linked recessive. You will think of skid first. Okay. What is the typical of this called Albrecht syndrome? That is having recurrent chronic skin infection. The key point to recognize Wisport Albrecht syndrome is thrombocytopenia. Okay, what about chronic granulomatous disease? This, whenever in a patient you will have history of the abscess. That abscess may be in the skin, in the perianal area, in the any like urethral site, in the GIT side, right? Then you will think of chronic granulomatous disease first. So, in the this question took me to the diagnosis of X-linked A gammaglobulinemia. Why? Why not? I said this NBT test that is done for which disease? Nitroglutazoline test is done for which disease? That is done for chronic granulomatous disease. Is the child is presenting with recurrent abscess? No. That is also an X-linked recessive, but there is no history of the recurrent abscess. That is the key point for diagnosing CGD. Bone marrow aspiration. Is that a syndrome of Wiskott-Aldrich? Have they given me any clue towards the thrombocytopenia? No, not at all. So the child is not less than 6 months. It's not a skate. They have not given any option that is to diagnose skate, right? 5-year-old boy, his uncle was also a boy. It's a X-linked recessive, and among the option, my answer is immunoglobulin level because this is a case X-linked agammaglobulinemia. Okay. What is the another difference? See, I told you one approach is to look for X-linked recessive. Okay, which one is autosomal dominant or recessive? Second one is to look for any immune deficiency, like whenever you have any infection, any germs that is going into your body, you have activation of the lympho-reticular endothelial system. There must be hepatosplenomegaly lymphadenopathy at least. Whenever you have history of recurrent infections, but the patient is not having any enlargement of this lympho-reticular system, you must think of two diseases. One is again the same, that is X-linked agammaglobulinemia, and another one is KIT, right? Multiple infections, they are present multiple times. Infection was there, but there is no lymphadenopathy, no hepatosplenomegaly. This may be SCID, this may be X-linked. Again, both are X-linked recessive, they must be present in the boys. How to differentiate? This is the age of the presentation. SCID will present earlier in the life, and X-linked agammaglobulinemia may present later on too. Okay. So one approach is for inheritance, another one is for to look for lymphadenopathy present or not. Okay. One immune deficiency that usually presents with lymphadenopathy and hepatosplenomegaly. Which one is that? This is AIDS, HIV. HIV is an immune deficiency which will present with enlargement of the lympho-reticular endothelial system. Okay. So these three approaches, they must be memorized for solving these questions. Okay. So I will move to the next. This question is clear to all of you. Is that clear? Is that clear? Okay. I will move to the next question. See. Okay, okay, I will do. Uh, uh, Dr. Kuranga, we have discussed this question number one, right? That was immune deficiency. I gave you the approach, how to diagnose, how to how you will approach for solving these recalls. I have not discussed the immune deficiency, what is D type, what is C type, and what are others. Okay, so this is a 5-year-old boy. He's a boy who has history of recurrent skin infection, pneumonia, and meningitis. And his uncle died during the childhood from the meningitis. What is the investigation? So first of all, we have to make our diagnosis. In this scenario, they have given me a clue towards X-linked recessive immune deficiency. What are those X-linked recessive immune deficiency? Memorize them. Write down into your copies. Number one is X-linked A gamma globulinemia, that is Bruton disease. Number two is the SCID, severe combined immune deficiency. Number three is the Wiskott-Aldrich syndrome. And number four, that is chronic granulomatous disease. How they are presenting X-linked agammaglobulinemia, that is going to present with what happens basically in this X-linked agammaglobulinemia. The stem cell that is going to differentiate into B cell and T cell, right? In this disease, there is failure of differentiation of the B cell into the stem cell into the B cell, which is going to produce antibodies. So, in the blood, you will not have B cells. There will be absent B cells and normal T cells, right? So this is a, and it may present like after 6 months. Why? Because immunoglobulins from the mother, they are present in the child, in the infant up to 6 months. Any immune deficiency due to this antibody defect that will present after 6 months. The next we discuss that is the SCID. Why SCID? SCID is an X-linked recessive where there is defect in the T cell as well as in the B cells. No T cells, no B cells, right? And it is going to present within 3 months or 6 months. Okay, so next is the Wiskott-Aldrich syndrome. The key point here, Wiskott-Aldrich syndrome is also a defect of both B cells and T cells, right? But there is a key point, a key feature in the Wiskott-Aldrich syndrome is what? That is thrombocytopenia. It's an X-linked recessive with thrombocytopenia, any infection that is suggestive of immune deficiency. What are infections which are suggestive? Unusual infection, unusual organism, unusual response to antibiotics. Next, we talked about the chronic granulomatous disease. What is that? Any disease, any scenario, wherever you find history of the recurrent abscess in a boy, you must think of this chronic granulomatous disease. So, among the options, the question, what was our diagnosis? That was X-linked A gamma globulinemia. Why? Uh, Immunoglobulins we have selected because the boy is present. Uncle was also a male, so it's an X-linked recessive. Why not NBT? That is done for the chronic granulomatous disease, but there is no history of frequent abscess. That's why we are not thinking of bone marrow aspiration. That is to make a diagnosis of Wiskott-Aldrich, but they have not given any clue towards thrombocytopenia. Okay, so this was one approach to solving this question. Next we will move to this question. What is that? An 11-month-old patient with low platelets, thrombocytopenia, just a minute, thrombocytopenia, okay, thrombocytopenia, dermatitis, not responding to emollients and hydrocortisone. He presented with a history of 2 lower respiratory tract infection. All investigations were of normal range except thrombocytopenia, platelet 39. What is the most likely diagnosis? I said any immune deficiency with low platelet, straightforward, go towards the diagnosis of Wiskott-Aldrich syndrome. Okay, why this is not a case of ITP? We said any normal child where all investigations are normal, but there is decreased platelet count. This is an ITP. So clue here for the making a diagnosis of immune deficiency is what? The first clue for making any diagnosis of immune deficiency is the skin involvement. When you do have involvement of the skin with other systems, especially respiratory or GIT or CNS, that is a case of immune deficiency. So here they have told us about the child is having dermatitis and thrombocytopenia. So this is not a case of ITP. ITP is not dermatitis, there is petechial rash in a normal child, right? Fast milk protein allergy, that is not going to present with this dermatitis with low platelet. That is dermatitis like any skin involvement plus eosinophilia. So that is why this is not a case of post milk protein allergy. Okay. Next, question number 2. Data about immunoglobulins M and G, they were low, like they are talking about A gamma globulinemia. What is the definitive treatment for this case? Definitely, that is parenteral immunoglobulins. Bone marrow transplantation, that is not the treatment for the X-linked A gamma globulinemia. In the X-linked A gamma globulinemia, what is the treatment? You give IVIG or other immunoglobulins. Systemic antibiotics, that is not a that is the treatment, but it's not a definitive treatment. Bone marrow transplant is definite treatment for which immune deficiencies? Write down, please. That is for CGD, that is for Viscott-Eldridge syndrome, and some others. So, definite treatment, you must know what are the definite treatments. Next is this one again, a 2-year-old boy, recurrent otitis media and previous meningococcal meningitis at 4 months old, physical examination, no lymphadenopathy, no splenomegaly. What is your diagnosis? So this is the second approach which I told you before. You must think of what is the inheritance. You guys can't hear? Can you listen to me? Can you hear, please?
Yes, ma'am.
Yes, ma'am.
Okay. So why someone is saying I cannot hear?
Voice is little soft, ma'am.
Okay, just 1 minute. I will make it loud. Okay. So now it's okay.
Better, ma'am.
It's better. It's not okay.
Okay, ma'am. Okay.
Okay. So I'm discussing this January 2021 question, right? A 2-year-old boy, recurrent otitis media, recurrent infections, physical examination, no lymphadenopathy, no splenomegaly. I talked about this earlier, like any infection, whenever you do have infection, there must be activation of your lympho-reticuloendothelial system in the form of lymphadenopathy or hepatosplenomegaly. Whenever you do have infection without these hepatosplenomegaly and lymphadenopathy, you must think of two immune deficiency. Number one is KIT, right? And number two is X-linked A gamma globulinemia. So, why we is this a case of IgA deficiency? No, there is hepatosplenomegaly, and that is usually presenting with GIT infection, chronic diarrheas. Is this a case of SCID? Is this a case of SCID? Like I said, there may not be any hepatosplenomegaly and lymphadenopathy. Why this is not a case of SCID? Okay, why not? That is an X-link. It's a boy, right? And there is no age. Yes, SCID is going to present earlier in the life, so that is why it's not a case of SCID. X-linked agammaglobulinemia. Yes, they want to write this HIV. Is this a case of HIV? Is this a case of HIV? Or they are talking about combined variable immune deficiency? Combined variable immune, why not? in the combined. No maternal history. The child is 2 years. Maliha, why this is not a case of HIV? No, yes, that's an option, but always remember what is usual presentation of HIV? It may be by recurrent infections any, but what is typical of this HIV? This is lymphadenopathy. This lymphadenopathy, that is very typical usual presentation of HIV, right? Here they have specifically mentioned no lymphadenopathy, no splenomegaly. Write down another point for HIV. In HIV, you have hypergammaglobulinemias, right? Lymphadenopathy in the options in the records plus increased level of all immunoglobulins IgA, IgG, IgE. This is a case of HIV. Okay. Next, this is okay. Why not if they want to write this as a combined variable immune deficiency? That is also going to present with lymphadenopathy and hepatosplenomegaly. Okay, any disease, any immune deficiency which is having this lymphadenopathy or this hepatosplenomegaly, there are increased chances of carcinomas and malignancies. This is a common point for all the immune deficiencies, right? So this question is okay now. Should I move to next? Okay, so now, this I have taken from this survival guide where some key features of this infantile X-linked agammaglobulinemia, that is proton disease. This is combined immune deficiency and this is selective IgE deficiency, right? Very important point here between that is the X-linked agammaglobulinemia. B cells is not being produced in the X-link. So there is absent B cells and normal T cells. That is a key feature here. If we talk about the combined variable immune deficiency, B cell is normally produced, right? T cell is normally produced, but what is happening? B cell is unable to produce antibodies. So there is defective antibody production. Here antibodies are not also produced. Here antibodies are not produced. Here absent B cells, that is why not produced. Here B cells are very normal, but number of B cells is normal, but function of the B cells is not normal, right? So this is the difference between the two. Here in the X-linked agammaglobulinemia, no lymphadenopathy. In the combined variable, you may have lymphadenopathy and hepatosplenomegaly. Then they are talking about selective IgA deficiency. Definitely, when you have IgA deficiency, you will mainly present with IgE or these gastrointestinal symptoms, and there may be increased chances of giardiasis, other autoimmune diseases. Okay, right? So here they have given the answer that was from the reverse. For the X-linked agammaglobulinemia, IVIG is the treatment. There is no definite treatment by this the bone marrow transplantation. Okay, so next recall is that is about what? It's a child with recurrent infections, severe eczema, and not responding to the treatment. Not responding to treatment, okay. Nail candidiasis, multiple fractures, special features, broad nose. Father also has the same facies. What is the diagnosis? First of all, tell me what is the inheritance here? What is inheritance here? Okay, Melia, why? What is the inheritance here? X-linked. Why? Autosomal recessive? No. That is a dominant disease. When father is having problem, when the child is having problem, when the grandchild is having problem, what is the disease? That is an autosomal dominant, right? In the X-linked recessive, the first sign of the recessive is that there is skip generation. This was a carrier, or this was having the problem that was not present in the next generation, but it was present in the next one. So there is a skip generation. This generation is not having disease, this one is having, and this one is having. This is a scenario for the recessive one, when disease is present in all the generation 1, generation 2. This is an autosomal dominant. So what is pattern here? The child is having disease and his father is also having disease. It father is having, here they are not talking about the uncle, right? So this one is disease and this child is having disease, generation 1 and generation 2. It's an autosomal dominant. Which one is autosomal dominant? That is Job syndrome. Remember, this Job syndrome or hyper IgE syndrome, that is very specific, like it's having fractures, right? Facial features, same faces, special faces, immune deficiency, Job syndrome. What is the other name for that? It's an hyper IgE syndrome. Okay, they are talking about the chronic granulomatous disease. It's an X-linked and it is going to present with multiple abscesses, recurrent abscess. Hypogammaglobulinemia, again, due to the name of the father, they are trying to confuse you with X-linked recessive. No, but that is an autosomal dominant. It's not a case of X-linked agammaglobulinemia. I will show you a picture which I previously also showed you, that